Welcome, everyone. I'm Dick Deming. I'm Medical Director of Mercy One Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. Our topic tonight is the Iowa Cancer Registry, and who better to have as a guest but Dr. Mary Charlton, who is the director and the principal investigator for the Iowa Cancer Registry. She's also professor of epidemiology at the University of Iowa, and she just was the recipient of a distinguished researcher award from the University of Iowa from the Board of Regents. So welcome, Mary.
Thank you. Thanks so much for having me again.
It's great to have you. And Mary and I have had a chance to get together and know each other over the past several years. Mary also serves as the president of the Iowa Cancer Consortium. I happen to serve on the board. And Mary also went with us last year on an above and beyond cancer journey to Patagonia.
That was great. That was a trip of a lifetime.
So before we dive into the topic, let's get to know you a little bit. Where did you grow up in your formative years, and where'd you go to high school?
I grew up in Omaha, Nebraska, so just on the other side of the river. I went to Burke High School. It used to be what I thought of as West Omaha. Now it's just sort of in the middle.
How many in your graduating class?
Oh, I think there was probably about 400. My graduation class was pretty big.
School. And what was your claim to fame in high school?
Oh boy. I wouldn't say high school. I would say junior high. I was the first person to be able to shoot a 3-pointer on my basketball team. So my nickname was Mary Bird.
All right.
And everybody else got better and I never did. So
so you peaked really early.
I peaked early. Yep.
Okay.
I just played soccer in high school. I gave up basketball.
And when you graduated from high school, where'd you go?
I went to the University of Iowa. So I just I've only ever lived on Interstate 80. So I went over that way.
How did you happen to choose Iowa?
It's funny. I was on my way to Marquette to see if I could walk on and play soccer there. And that was 8 hours away. My parents were a little bit older. They were 42 and 52 when they had me. So it was a little bit of an accident. And they had bad backs by the time I got to college. And so we stopped midway in Iowa City to stay overnight on our trip. And my dad said, you really ought to think about the University of Iowa. It's a really good school. But when you're from Nebraska, you think, I don't want to go to Iowa. What are you kidding me? But I did take a tour of the school and really liked it. And they offered me the best kind of scholarship and deal. And so I ended up being a Hawkeye and have been grateful for that ever since.
And did you play soccer in college?
No, they didn't have a soccer team at the time. And by the time they got one, I was, I think, a senior and really out of shape. So never.
What was it when you started college? What was your very first declared major?
Pre-med.
Okay.
Biology. Yep.
And what did you graduate with? Your bachelor's in biology?
No, bachelor's of science in nursing, actually. I took a little different, wanted to stay in healthcare, but I didn't like the chemistry too much. Didn't enjoy that. So
I don't think I knew that you had a bachelor's in nursing. And then did you go right to graduate school, or did you work in nursing for a while?
I worked as a nurse for about a year full time. And I was the only one in my nursing school class who really liked the research class. Everybody else, couldn't wait to get into the hospital. And I was the one that was like, oh, it's nice in the classroom. I wasn't too sure about going over to the hospital. So I kind of knew early on, like, maybe this isn't the best, but I did work as a nurse for a year. And then that's when the College of Public Health kind of came out of the College of Medicine at the University of Iowa. And I had a teammate from high school, a soccer teammate, who came to get her master's in biostatistics. And so she looked me up and I was like, what in the hell is biostatistics? What is that? And so she kind of explained it to me and introduced me to her friends in the College of Public Health. And I found out about epidemiology and the rest is history.
And then did you go directly from your master's to your PhD? Was it a joint program or?
Yeah, no, I always like to take a little break, like to see where the grass is greener or not. So I finished my master's. I worked in family medicine for a while doing some research, and then I got offered a job at Wellmark, Blue Cross Blue Shield. And so I actually moved over to Des Moines, the other place on I-80 that I lived. And I worked for Wellmark for 5 years, and they were kind enough to pay for my PhD and give me the flexibility to sort of go back and forth. So
And how long have you been at the Iowa Cancer Registry?
since about 2010 is when I came
Okay.
back.
So, for those who don't know, what is the Iowa Cancer Registry and why is there such a thing?
Well, so the Iowa Cancer Registry, in theory, is a staff that collects 100% of cases of cancer diagnosed among Iowans. So anybody who is a resident at the time of their diagnosis is in the registry, and we collect a couple hundred variables about everybody with cancer. The only one we don't collect is skin cancer that's not melanoma. So we do collect melanoma, but not like basal or squamous cell because they're so common and they're not very commonly deadly, thankfully. So there'd be a lot of those to collect. So we that's the only one we don't do. And we follow people for the rest of their lives so that we can collect information about survival. And we pass that information along to the National Cancer Institute, who's our main funder.
And when did it become law that cancer is a reportable disease where it is by law we have to track all of the statistics related to cancer?
Yeah, that's such a, I wish I had that at the tip of my tongue. But the registry has been around since 1973, the
Right.
Iowa Cancer Registry. I don't believe it became a reportable disease until maybe around 1990.
Okay. And are there other diseases besides cancer that are required reportable? I mean, I think of infectious diseases.
Yeah,
There's all sorts of rules around
yeah,
collecting and reporting on infectious diseases, but other non-infectious diseases like cardiovascular or lung,
yeah.
it's not
There's
really required, correct?
no, there's really nothing like cancer. Part of the reason that with infectious diseases, it's a short form. They can just sort of fax over or send over. This person has Lyme disease or whatever the reportable condition is, and it's when did they get it and a couple things about it. But again, cancer, we're collecting hundreds of variables. Um, and it takes a real specialized expertise to collect that information. So what makes cancer so unique is that the federal government really invested some money and resources into establishing these surveillance systems. And there's not the National Cancer Act is what established the SEER program, and then some amendments to that established the CDC program that operates in the states that we don't have SEER registries. So it's really the only chronic condition like this where we have like near complete capture of cases and hundreds of variables about those. There's nothing really to compare it to.
And so obviously it's not just to collect the data and have it stored somewhere. There's value and we can learn things. So what do we do with the data once you collect the data?
Yeah. So, well, first thing we do before we pass it along to the National Cancer Institute is we take out all the identifiers so that nobody can be personally identified in our database, which is really important. There's still some protections on top of that to be able to use that data. But we pass that along, we clean it up, pass it along, and they put it all together into some tools that researchers use. And they've probably published thousands and thousands of papers using SEER data, looking at who gets cancer more, what are the characteristics of those people, what are the evolution of treatment in different types of cancers, and do some people that live in some areas get more treatment than people who live in other areas, and do certain treatments lead to longer survival, and things like that. So you can really ask and answer a whole host of really important research and clinical questions using that data.
And Iowa, obviously, at the Iowa Cancer Registry, one of the jobs is to collect all the data. Do you have set research projects that you oversee with the data every year, or do investigators that might not work for you but work at the university or elsewhere come to you and you assist them in collating and bringing the data together so that they can analyze them for research projects?
Yeah, thanks for asking that because I think that's a big kind of misperception that people have. We're not funded to do any research at the Iowa Cancer Registry. We are funded to collect the data, also given some support to report it, as we do like in the annual Cancer in Iowa report and other things. But we are not a research organization. So we work with researchers outside of the registry who want to use the data for research purposes.
Hmm. And I would imagine that that's a very important function that you do, because again, just having the data isolated in your department doesn't help as much as making the data available for researchers who want to explore certain research topics. In any given year, I mean, do you have hundreds of people coming to you and asking for help in doing research? Or how do you have enough staff to keep up on that function?
Yeah, that's the trick is to really meet the demand. A lot of people though, there's a lot of tools and resources through the National Cancer Institute that help people use the data, not just from Iowa, but from the other what we call SEER or Surveillance Epidemiology and End Results registries. Those are the ones funded by the National Cancer Institute. They have a lot of tools and a lot of expertise and resources to help people use that data for research. It's a smaller number that we get who come to the Iowa Cancer Registry and say, we really want to work with you directly to use your data to look at research issues. There's a lot of ongoing studies that we contribute our data to, one of which that I talk about a lot is the agricultural health study. That's one where they've enrolled over 30,000 Iowa farmers and their spouses in the study to look at different types of agricultural exposures. So they're the experts in collecting that information. But then we contribute our data to that study so they know who in their cohort gets cancer, what types of cancer they got, what treatments they got for that cancer. So we do a lot of those types of studies where they're called linkage studies, where we're linking them to existing research cohorts.
So, Mary, as you stated, every year you put out a report, Cancer in Iowa. And a couple of years ago, you can correct me at what year Iowa became number 2 in incidence. But over the last several years, the prevalence of cancer in Iowa has really become a topic that has brought on a lot of interest, not just from cancer researchers, but from the public at large. What are some of the other changes you've seen since 2010? You've been at the Cancer Registry. How has your role or the role of the Cancer Registry and the excitement and interest changed over the course of the last 16 years?
Yeah, a lot. We used to put out the Iowa Cancer Report or Cancer in Iowa report each year, and we'd have a little press conference, and we'd do a handful of interviews, and be really excited if anything kind of made it to the evening news, and then a year would go by before we'd do it again. And these last couple of years, I do probably 1 to 2 press interviews a week, year round. They've really gotten a lot more attention. Which is great. People are talking about it, wanting to do things about it. So that's really exciting, but it's been a challenge because it's a new responsibility that, people weren't really knocking down our door. Just the amount of, talks, giving a talk at Iowa, I think Oncology Nursing Society, the Iowa Osteopathic Medicine. Like I give a lot of, we could ask the Rotary clubs, all kinds of things. And that was kind of the thought behind the 99 counties a little bit was to, how can we give each community a lot of information about their cancer burden in their area so that they can do more, because we're having a hard time keeping up with the demand. So how can we just be proactive and put this information out there for people across Iowa to use?
And for those who don't know, maybe say a little bit more about the 99 County Project. What is that project?
Sure. So kind of the the thing that sort of inspired us the most to do that was at one point Palo Alto County in Iowa was showing up on State Cancer Profiles. It's a CDC website where they show the rankings by state or by county. You can get rankings by county of different cancer types. And Palo Alto County was showing up as having that being the county with the second highest cancer incidence rate in the country. Of course, the people of Palo Alto County were, kind of shocked by that, as were we. So we started to dig in and try and figure out like what's going on in that county, what would be driving that, what could be some factors going on. And so we did a real deep dive and offered to present that to people in the county, and they asked us to present at a Chamber of Commerce meeting. And Palo Alto is a pretty small county, so we thought we were zooming in to do it, and we thought we were just sort of talking to a small room of people on the Chamber of Commerce. And we found out from a newspaper article the next day that there were over 150 people in the room who were really interested in hearing about that. So we thought we should that'd be a good thing to do for all the counties in Iowa. And so I got a grant through the National Cancer Institute, and we learned how to use Tableau, which is a really cool program that helps us put reports together with really beautiful graphics. And we did a lot of work to try and make them as just understandable and digestible by a public audience as we possibly could. We're constantly tweaking those. And so we go around. Sometimes we have to do it by Zoom, especially for Northwest Iowa. It's really hard to get up there from Iowa City, but we do try to get around the state and go in person when people really want us to come in person and deliver this information and give people resources and ideas and things that they can do in their community.
So, I was honored to be able to participate in the Polk County 99 Counties project, and you can slice and dice data in many, many different ways and beautiful graphics. Many of the people want to know why, and as you pointed out, that's a more difficult question to answer. It's sort of sharing the data. I mean, it's a lot of hard work in collecting and collating the data, but the question as to why Iowa's number 2 is much more difficult to answer than it is to state it as a fact.
Yeah, that's absolutely true. And I think, kind of what's happened is we're the ones out there talking about cancer, and people have a lot of questions. Like you said, what is causing this? And so that's been a challenge because we don't collect risk factor information on people. No cancer registry collects risk factor information, especially environmental risk factors. We're nurses and medical record technicians, who are and across the state. It's not just us at the registry collecting the data. We have partners at your own cancer center across Iowa. It's your own people in those larger cancer centers that are collecting the data. And those, again, are nurses and health records technicians. All our information that we collect at the Iowa Cancer Registry comes from the medical record. And so, as you can imagine, there's not good risk factor data that's consistently collected in that medical record. So, so that's been hard. I think it's been good though to kind of push the state of Iowa and other stakeholders into kind of joining the party here. We can give one piece of the puzzle on what's happening, what types of cancer and what stages of cancer and those types of things are driving some of our rates. But to really get at the why, we have to have more research, more data collection of those different risk factors and things like that to really be able to get at that very important question.
Does understanding that risk factors are important, does that lead to maybe changing how data is collected? So, for example, the idea of, was the patient a smoker or not a smoker? So now with nearly everyone on electronic medical records, that's a question that is built into the electronic medical record. Do you smoke? Did you smoke? When did you quit? Is there a push to, since we know that there are certain activities that are risk factors, to be able to collect that data and to have that as part of the data that is submitted to the registry?
Yeah, and that's where it gets a little tricky too. We have the Public Health Authority to collect cancer information on behalf of the state of Iowa. The Department of Health and Human Services sort of designated the Iowa Cancer Registry as the public health authority to collect that information. As it says in the state code, we are allowed to collect, or we have the public health authority to collect whatever the National Cancer Institute SEER program tells us we have to collect. So they sort of set the variables that we're collecting, and they don't generally require that we collect risk factor information. Now, there's a little bit of gray area where we've started to, there's a spot to put it. So we've started to collect smoking information to see how consistently that's collected, so that we would be able to look at that more. So that's definitely one that we're looking at. You would be surprised, though, how many times it's not there in a consistent way. And I think that's one of the reasons, I'm getting into a different topic, but lung cancer screening, it's one of the reasons that's so low, is because you have to be able to compute pack years and things like that in the medical record to then go on and do the screening. And it's just not, it seems like a no-brainer and that it would be easy, but there's lots of different medical record systems and lots of different ways to put that in. And a lot of times things you think would be there every time just aren't. So it's just a challenge.
Right. So we mentioned smoking. And so as we get, refresh my memory, how many years has Iowa been number 2? And did we move up from like 4 to 3 to 2? I don't remember that we ever talked
Yeah.
about our rank until we got to 2, but we must have over the past decade have slowly gone up, or did we quickly jump from 10 to 2?
Yeah, there was a couple jumps there, but it was really, it's really around 2013 when things started to increase, where the rest of the country was decreasing or staying stable. Like that's the year. I say that though, and then people's kind of knee-jerk reaction is, well, what happened in what happened in 2013? And that's the hard part, is cancer takes decades to develop, so it's probably not just something that happened in 2013. It's probably something that happened in 2003 or 2010, or somewhere in that spectrum of time. But we've looked at our data. We've looked at hospital by hospital. Was there a certain bump somewhere? Like, is there something different in how we're collecting the information? Is there some kind of explanation for this? And we just have not been able. It's just sort of across the board, and we're high in just so many cancers. It's not just one, and it's not just in one area of Iowa. Some people ask, hey, you're a really good cancer registry. Are you sure you're just not better at collecting the data? And in some ways we are. Like, I would go out on a limb to say we are better at collecting the data than some of our lesser resourced registries in the country, like Nebraska. They're not funded by the National Cancer Institute. They have a much smaller budget, a much smaller staff. It's likely that we, just on some consistent level across time, probably catch more cases than the Nebraska Cancer Registry, for an example. But if we compare ourselves to the other SEER registries, the other ones that are very comprehensive and funded by the National Cancer Institute, our rates are different from them too. And as good as I think we are, we're not outdoing ourselves every year. So I don't think we're getting better and better, and that's sort of accounting for more cases.
Mm-hmm.
So there's a little bit of that, but by and large, I think the year we look at the most recent 5-year time period to look at our ranking. You can either look at the current year, or you can look at the most recent 5 years. And rates kind of jump up and down. So we prefer to look at the rolling 5 years. And I believe it was in 2023, but looking back, the cancer lags. So it would have been like the 2017 to 2021 time period where we became number 2. And then each rolling time period since then, we have remained number 2 with an increasing rate, while the rest of the country has either a stable rate or a decreasing rate, save just a couple of other states.
And that's a very important distinction, is that we continue to go up. And correct me if I'm wrong, I think the Utah might be the only other state where the rate is going up a little bit, but that every other state, the incidence is going down. So with Kentucky being number 1 and its incidence going down, and Iowa being number 2 and the incidence going up, what would you, if things don't change, when would Iowa unfortunately become number 1?
Yeah, I think we're about 500 cases per 100,000 right now. And I think there's still, I would have to look, but maybe around 515 cases per 100,000. So not a huge difference. And they've been number one since they started keeping track. Like Kentucky has always been number one. So that would be a big deal for them to cross with another state. So it's possible. It does look like Iowa's leveling off a little bit. And there's a lot of states that are just stable that aren't going down. But there are predominantly mostly states that are seeing a decrease in their cancer rates. So, but I think our Midwestern partners, like a lot of people are kind of flat. And you pointed out Utah, which is going up, but it's a very different state. Utah is going up when they have one of the lowest cancer rates in the country, as opposed to Iowa going up, which, has one of the highest rates in the country.
So when you think of incidence, the cancer, and we know risk factors, we know quite a few risk factors. And I know that, as you mentioned, the Iowa Cancer Registry doesn't actually collect all the data on risk factors. So we have to rely on other sources. And almost all of those sources are just asking individuals in surveys whether they smoke, what they eat, what they do for physical activity, what their weight is, how much they drink. Those are all sort of voluntary questions. And we collect those and then try to collectively say, where does the state of Iowa stand relative to other states in those pieces of information that is collected through polls. As you mentioned, we also know that the environment plays a role in cancer. Radon, we know for sure. And we also know that there's other chemicals throughout the environment that can lead to cancer. That's a much more difficult thing to track. And some of those are not actually officially tracked. Is that correct?
Yeah. Yep. I would say that even something like radon, you'd think, well, how hard is that, to measure, but pretty hard. We know a lot of the testing is reported through the state, but the nature of radon, one house can have a high level and the next house next door doesn't. It's really hard, even on a state level. Like we're trying to build some models predicting like what different state rates should be, just to think about trying to get a radon variable at a state level has been really challenging. Also, again, challenging at smaller granular I can't say it, granular levels, because it's all dependent on who's tested their home. And there's a lot of people who have never tested their home for radon in Iowa. So even that one's a tricky one to get.
So, a year ago, the state legislature set aside, I think, $1 million to start to challenge the University of Iowa to do a study to help determine why the incidence of cancer is so high. I think you're on either the panel or the advisory board or one of the entities that is helping to
Sure.
do the research. That would be a huge undertaking. $1 million is $1 million, but probably not enough money to really move the needle. What can you tell us about how that research is being structured? What even if you had an unlimited amount of money, what would you do to try to answer the question, why is Iowa's cancer incidence going up?
Yeah. So in the first year of the project, I think we're about, I think that came in July. So we're coming up on a year this summer from when it started. Kind of have to build some base models of, what predicts a cancer rate. So we started with things like you were talking about the CDC's behavioral risk factor surveillance system. So that's again asking people, do you currently smoke? How much do you drink? All kinds of, do you get screened? Those types of questions. So we have examined those. Also, a lot of demographics from the American Community Survey. I think people kind of don't realize the incredible impact of demographics on cancer rates. And I think part of the thing to remember is two things have to happen, two just big buckets of things have to occur to get into the rates. First, you have to be diagnosed with cancer. And second, someone has to find the cancer. Those are two things that have to happen. There are probably lots of people that live long, happy lives, never knowing they had prostate cancer or things like thyroid cancer or something like that never caused any problems, never were. They died of something else before they knew it. What's interesting about Iowa and what we're learning from the statisticians that are working on the project who have created sort of these state clusters, who are we like in terms of behaviors and demographics, and then how does our cancer rates compare to those states? Kind of what we learned from that is, Iowa kind of has this combination, so there's states with healthier behaviors than we have. They're healthier, they have good sociodemographic profile. They're not very poor. They have good access to healthcare, and they have healthier behaviors. They have low smoking rates, low drinking rates. Think of some of the outdoorsy states like Colorado. People are out and moving and exercising a lot. And those tend to have some pretty low cancer rates. Then there are states like the South, where you see really not good behaviors, like in terms of smoking and other things, but poor access to healthcare. And so there you're seeing they're probably getting a lot of cancer, but they're not finding all the cancer. And people have a lot of competing health risks too. So, but then you have the upper Midwest, Iowa, Minnesota, the Dakotas, Wisconsin, where we have not great behaviors. They're not, necessarily as bad as the South, but we real high binge drinking. Like we're blowing everybody out of the water, unfortunately, on ones like that. And other kind of not favorable behaviors, but we have pretty good access to healthcare here. We have good, especially in Iowa, even though we're a rural state, you don't really have to go very far to get screened and get services. And we have a pretty good healthcare systems that work together across the state. So we're getting a lot of cancer and we're fighting a lot of cancer. And that seems to put our cluster above all the rest. So the Midwestern cluster has the highest rates. The good news about some of that is like a lot of that's driven by early stage breast and prostate cancer. So finding those cancers really early when they're treatable. And that's a good thing. Melanoma too, like finding a lot of melanoma, but finding it early. The one that's not good, and especially not good for Iowa, where we are different from our Midwestern peers, is lung cancer. We have a much higher incidence of lung cancer. We have a higher rate of late stage lung cancer and a higher mortality from lung cancer. There's no explaining that one with, we have a good healthcare system. We're finding more. So that, to me, that's the most troubling one of them all.
And that might be one where radon is part of the explanation. And as you pointed out, and we'll do a little bit deeper dive, that lung cancer is one of the cancers for which we have a validated screening test. But unlike breast cancer, which is mammograms, every woman can get a mammogram, and almost 80% of eligible women do get the mammograms. Every man can get a PSA for prostate. Every man and woman can get screened for colon cancer, but you can't get screened for lung cancer unless you tell someone that you are a smoker or were a smoker, and that you smoked, 20 pack years, and you do the calculation. So if you don't say that to a medical person, you don't actually get screened for lung cancer. And as a result, what is it, about 17% of
18%,
only 18% of Iowans that are eligible for lung cancer screening get screened. And lung cancer kills more individuals in Iowa and the United States than any other type of cancer. Yet we have a screening mechanism that can find it at an early stage, but it is not being utilized.
That's right.
So let me just ask a question about the researchers you're doing and the risk factors. What would it look like to try to do a deeper dive into the more difficult thing to track, and that is environmental exposure? I mean, we have, about 75% of the geography of Iowa is land under cultivation, and current modern cultivation techniques uses a lot of chemicals. And what would be, how would we even devise a way of trying to evaluate what role the environment, we talked about radon, but the other chemicals, how would we come about, what would be some ways in which we could look at that more deeply or consistently?
Yeah, and that's kind of getting outside of my scope, which is more in year one and into year two, where there's other environmental experts that will help do that. Um, but it's really hard because states like California have this amazing pesticide reporting system in place. Um, Again, I'm not a very good expert to speak to this, so fact check everything I say here. But most of the pesticide information we collect in Iowa is at the county level. It's sort of like what's purchased. It's not very specific. And pesticides, are hundreds of different chemicals. Where again, in like states like California, they have this kind of amazing reporting system where you can drill down on that and understand more about the chemicals and things like that. It's still a source of data to look at pesticide usage by county. And so I think that's one that they'll be considering using. Nitrate levels. There again, it sounds like it should be pretty easy, but it's like my understanding of that reporting system. There's different ways to report nitrates, and some test reports it one way, some test reports it the other. Somebody tried to convert one to the other, and there's an error, and so there's kind of crazy values, and people try and go through and clean that up. The issues of a lot of those too, like take nitrates, it's top of a lot of people's minds. Nitrate levels now, I don't predict cancer now. That's something that happens over years and decades. So there are some people who drank out of one primary water source for the last 20 years straight, but that's not always the majority of people are moving around. And so there's no good longitudinal record of all the different places that they've lived, and did they drink out of a well or the city water and what was in the water. So you're just looking at this sort of point in time. Maybe see nitrate levels 10 years ago and try and relate it to cancers now. It's just really it's worth doing. We have to try and use the data that we have to try and quantify that risk a little bit better and understand the relative contribution of that. But it's like smoking though, that's like you said, that's a point in time again from a survey, and who might say the percent that say they smoke now might be different from the percent 20 years ago. And so we have to kind of figure out how to lag that. Like, okay, the smoking rate now doesn't explain the lung cancer rate now. We got to go back. We got to figure out what's the right time period to use that. The radon level doesn't explain the lung cancer now. We got to go back in time, and there was less testing back in time, so we don't have great data from when that might have happened. But you just do the best you can, try and use all the inputs that we can, and hope that people like you and others that advocate for things can advocate for better data collection systems, monitoring, so that we have that data that we can kind of feed into models, try and figure out, what set of factors working in combination would explain why our rates are so high.
We've been talking about incidence, and the incidence in Iowa is going up, and we're number 2. Let's talk about mortality. So mortality is how many people die of cancer, and is it really a manifestation of did you find the cancer at an early stage, and how is the cancer care that you're getting in that state? So, the bad news is our incidence is going up, but the good news is we are kind of in the middle of the pack in terms of mortality. So we have a lower death rate than many states. Would you say that we are in the middle of the pack, or are we even better than that in terms of our mortality?
Say we're very average, incredibly average, right in the middle.
Okay.
So that's a good thing considering our rate. That's really saying something about our efforts to detect cancer early, and the treatment that people are able to get. That's really a testament to our different healthcare providers across Iowa that we have that sort of interesting mix of a increasing incidence and a declining mortality.
Earlier, you talked about the county of Palo Alto. Do you know off the top of your head approximately how many people live in Palo Alto County? Are we
Oh,
talking?
maybe like 6,000. That might be
Okay.
on the high
Okay.
end, but
Yeah.
somewhere around 6,000 people.
But it makes me stop. It makes me think about the idea of cluster, and probably a whole county isn't a cluster. Maybe define what is a cluster. I mean, we hear about it probably once a month. Somebody will say, 4 people on my block have just been diagnosed with glioblastoma, and there's got to be something. What is a cluster, and what role does the Iowa Cancer Registry play in investigating possible clusters?
Yeah. Well, I would say if 4 people on your block were diagnosed with glioblastoma, that might do it. That might be a good definition. When we think of clusters, like the pure term cluster, it's usually like a rare type of cancer that is sort of all of a sudden getting diagnosed in similar space and time, where at a rate that's far more than expected for that area. And it's generally like the same type of cancer. That's where, a lot of people we've done a cluster investigation. So you asked about the role of the registry. Is anybody who, emails us or contacts us with a concern of a cluster, we will talk with that person and kind of figure out, well, which cancer, are you kind of concerned about? How many people are we talking about? What are the bounds? Like, is there an exposure that you're worried about? And how would you draw a box around the area that you're concerned about? And then we can compare it to like a similar community that maybe wouldn't have that exposure of concern, but is similar in other sort of characteristics. So we can kind of figure out what's the expected number we should have and how does that relate. But there have been sort of concerns where people say, oh, I know a lot of people that got breast cancer in this town over, kind of a relatively long time period. And we will absolutely investigate all of those. We definitely want to keep an eye on anything. And we don't want people to be scared or, really worried that there's some kind of point source exposure in their area. But one that's kind of hard with breast cancer is, as you probably know, Dr. Deming, it's kind of a lot of different diseases lumped into one. And so a lot of times when people say, I think I see this breast cancer cluster, we'll go back and look at our cases in that area. But a lot of times we'll find like, okay, well, some of them had this subtype and some of them had this subtype and some of them had this subtype. So it's probably not the same thing that's causing these sort of different types of breast cancer. But we'll still do the investigation. It's a really good opportunity to talk with people and kind of educate them about the different risk factors. There's lots of different ways we can do it. So it always ends up being a good experience. I hope people, kind of appreciate, even when we don't generally find very many. I think the last time we identified what would have sort of met criteria for a cluster was back in the 90s in Wellman. There were some people with brain cancer, and we did call the CDC and they did come and investigate, but they were not able to determine a source of what might have been causing the brain cancer. So haven't really ever kind of found a source of one before.
But people who suspect there's a cluster, there's a process they can reach out to you, and you do have a process where you will investigate that. And but it's often not successful in actually determining. I would imagine most of the time the statistics turn out that you are aware of these, but that it really wasn't a amount of cancer that was significantly different than other areas. It's just that once you have a certain type of cancer, you're just more aware of that. And to your knowledge, you've identified one situation where it truly met the definition of a cluster, but in analyzing that particular location, you couldn't come up with an explanation for what it might have been in that area that actually contributed to the increased cluster
Yeah.
of brain
Yeah.
tumors.
Like the CDC in the past, I'm not sure who's left at the CDC in the present, but in the past, they would send people out and they would do what's called a case control study. And so they'd, get a get information about the cases. In the Wellman example, the people that had brain cancer, or if they had passed away, they'd ask their relatives about different exposures that they had, and different things about where they lived. And then they'd ask people who didn't have brain cancer but were similar to the people who got it in other ways, and they'd ask them, like, well, what were you exposed to? And they kind of go through a whole list. And they just couldn't find anything that was different about the brain cancer cases from the non-brain cancer cases. So that's usually how they, in the past, would go about it.
So we're going to open up to questions here. So we have a live studio audience with me. They're going to get first shot at you, Mary. And then those of you that are watching us live streaming, you can put your questions in the comment section of the software that you're using. But we'll start off here. Angelina, you get the first question for Mary.
Hi. Yeah, I just shared with Dr. Deming that it's now on TikTok and a lot of social media that came out about from the Des Moines Register on the zip codes and how their highest rate. And a friend shared it with me, and I went, oh, yeah, I'm 5 miles away from that zip code. But yeah, I got breast cancer 4 years ago. And so it's the concern, which I'm glad it's making people aware, but that's also scary them. What would you suggest? In fact, the friend who sent it to me is freaking out. And I go, what would I suggest? You suggest me refer her to look at the data, to kind of calm things down a little bit. I mean, it's good to make that awareness, but not to make hysterical awareness.
Yes.
Or are you going to recommend? Or are you going to recommend they move to a different zip code?
No. I'm so glad you asked that question. I am just so sick about that story. We did contact the register immediately after the story and said, you got it wrong. That's not right. They do not have 100 times the rate of breast cancer in Urbandale compared to Fort Dodge. It is two times higher, and there's good reason. We would expect it to be 2 times higher. I don't believe there is any exposure that's causing breast cancer in Urbandale. Can't rule that out. But one huge predictor on a population level and an individual level of breast cancer rates are the college education rates of an area. And that is because the more educated women are, the longer they tend to wait to have kids. And the longer they tend to wait to have kids, the higher the rate of breast cancer, the higher the risk for breast cancer. It's just how breast cancer works with all the hormones. You're better off just pure risk for breast cancer of having kids early. There are about 1,000 reasons not to have kids really early. They're a pretty fair trade-off. I would not recommend that people get less educated in Urbandale. And one claim to fame that you have in Urbandale is you are one of the most highly educated zip codes in the state. You have one of the highest college education rates in the entire state. And for reasons not clear to me, they compared Urbandale to Fort Dodge, which has one of the lower education rates in the entire state. And that is why you see a big difference in those breast cancer rates. When we looked at Polk County and when the biostatisticians did all the modeling for the project that Dr. Deming asked about, the $1 million allocation from the state legislature, there were no excesses of cases of breast cancer in Polk County. Now that was at the county level, and they haven't run the models for that zip code level, but I am extremely confident that it is not anything happening in Urbandale. It is just the demographics of that area. And those are good things. And I'm not trying to minimize like that. No big deal. Breast cancer is high there. That is a big deal. It's definitely something to be aware of, but that's what we would expect based on the demographics of the people who live there. So I actually, go ahead.
No, I'm sorry. What are other demographics that go hand in hand with the diagnoses and incidence of cancer? So you mentioned education. What are other demographics that predict for either a high or a low rate of cancer?
Purely demographics. I would say like upper socioeconomic status, and that kind of goes along with education, but the sort of wealthier an area is, the higher the breast cancer rates. It also has a function of, like, I would venture to guess almost everybody in Urbandale has health insurance and a good healthcare provider really nearby. You probably have a very high screening rate for breast cancer. And, I'm not saying that there's like lots of women in Fort Dodge walking around with breast cancer who are not getting screened, but it's possible. There are breast cancers. It's possible that you can live a long, happy life with a slow growing breast cancer and not know that you had it. So that's kind of another thing. So the more well off, the more white your population is, the higher rate of or proportion of white people, the higher the rate of breast cancer. So there's all kinds of things like that that go into it without even sort of getting into the behavioral risk factors. But I think that's one thing that we asked that they correct in the story, that they thought, just correcting the numbers was fine, but I wasn't fine with them still kind of doubling down on portraying Urbandale as a hotspot and remade a TikTok video still with the same message, even with corrected numbers. So I'm doing an interview tomorrow with KCCI with Suzanne Benke. I really wanted to set the record straight. The reporters can get it wrong a lot, but when it scares people to the point, we've been getting a lot of calls and emails about it. People who, hey, I just moved to Urbandale and now I'm afraid that I'm being poisoned here and what's going on. So I'm going to try to get the word out that way. I know that the mayor of Urbandale and a pediatrician in Urbandale who are really concerned about it are writing a letter to the Des Moines Register. I also provided their names to be interviewed for this story. So we're trying. I was going to write an op-ed to the Register, but nobody's subscribed. Like if you don't have a subscription, then you can't see it. So we're trying to do some other avenues of getting the information out there that, A, the reporter got the numbers wrong, and B, they got this sort of interpretation wrong. And those maps have been on our website in some form or other for 10 years. And this is they're kind of more meant for public health professionals to kind of figure out, where are some high late stage rates of breast cancer where we might need to focus some efforts, or where, looking at different things. And so I'm not sure why he got excited about this particular one. And I feel really awful about what the damage that it's caused in Urbandale. So we're going to try and get the word out about that.
Thanks, Mary. Another question, Gary.
Yeah, a lot of questions. I don't know what I can remember, but I'm curious as to, with the AI coming in more and more, is that something that is coming in to help in your research and to be able to collect data and to be able to organize it better, and also to help in those that are doing research? And then I have one question about
Let's do the AI question first.
Okay.
So the role of AI in research.
Yeah. I can't speak to it as much in research since I'm more focused on surveillance when it comes to the registry, but we're always looking for ways to collect more information with less people. It's a really niche kind of profession, the cancer registrars. And a lot of them, unfortunately, are retiring soon. So we're going to really need to rely on some more technology, unless it's really difficult to replace them as they retire. So absolutely. Unfortunately, there's still a lot of decision making that has to happen when logging cancer, and the way that the medical records work, like even just finding the date of diagnosis, that can be a real challenge, and sometimes takes a human to kind of figure out what all happened when from all these different records and consolidate that and come up with the data diagnosis. So we're always working towards that, and we do hope AI will make that more efficient.
And theoretically, as we get more unified electronic medical records, you would think that as those data go in select cells, that they would be easier to pull out with less human looking at a record. Yeah.
A few doctors could all put it in the same spot every time and use the same words. Hey.
I hear you. We would just pass it down to the nurses, and then the nurses would pass it down to. No, I do believe that we're on a path that will make that collection of data easier. So
absolutely.
Another question?
Yeah.
Okay, Gary.
I'm curious, with the you're talking about the 99 county projects, that has that showed that there might be higher incidence of counties within certain areas of the state? Or is it pretty uniform?
I wouldn't say it's uniform. I would say each cancer type has a little bit different pattern. So we see higher rates of lung cancer in the southern counties, higher rates of melanoma in the northern counties, higher rates of breast cancer in the cities, because that's where the mostly educated people tend to organize themselves there. And we see a lot of colorectal cancer in the rural areas. Maybe they have less access to things like colonoscopy or different behaviors. So yeah, each cancer has a kind of different pattern to it.
Okay.
Yes, I'm assuming that cancer doesn't know where the state line is. If you went up to northern Iowa and you included a tier of counties out of Minnesota, and you go down to Missouri and pick up the top, would you see anything different?
Yeah, we have been doing that to the extent possible. Like I said, our surrounding cancer registries and our surrounding states aren't quite as comprehensive as ours is, but to the extent we can get that data, we do see like the melanoma sort of carries over, those high rates carry over into southern Minnesota, and the higher lung cancer definitely carries into northern Missouri. So absolutely, but the absolute numbers of the cases might be a little lighter in some of the like kind of surrounding counties than here. So we have to sort of be careful in that interpretation, but absolutely we look across state lines wherever we can.
Okay. We have time for one more question for Dr. Charlton. One more question. Angelina?
Yeah, we're talking about the different types of cancer, and I just saw a commercial about how the colonoscopy, the colon one, you can do Cologuard. Now there's probably a patch to check on cancer. Have you heard of that? It's now coming on commercials of detecting cancer.
A patch, did you say?
Yeah, and to send it.
I don't know that one.
There are blood tests.
Or blood test. Maybe it's a blood test.
Certainly.
Yeah.
Mary, do you want to talk about the?
Yeah, you probably know more about it than I do, Dick. But I think the jury's still out on those being sensitive and specific enough to really make a difference. I think this in some early studies, like they don't seem to be reducing mortality in the way that you would want a test like that to do, and they kind of stress people out when you think, well, you got cancer somewhere, but we can't find it. But I don't know, Dr. Deming, you might have more to say.
So we have covered that on this show, and there's no doubt that the science is there that you can detect circulating cancer DNA in the bloodstream. But so it is already being used for people who have a diagnosis of cancer, and we're using it to follow. But they use it as a screening. In order for it to be valuable as a screening, you have to check people who don't have symptoms, and that by checking them, you're able to reduce the death rate of that cancer. That's what makes it valuable as a screening test. So the science is clear. You can find the cancer cells, the DNA from cancer cells, but we haven't yet seen evidence that using it across the entire population will reduce the death rate. So one of the companies, Grail, has the entire United Kingdom, hundreds of thousands of individuals that are using this test to see whether they can shift from later cancers in the people who don't do the blood test to earlier cancer. And that has not yet been shown, but the research continues. So, well, Mary, this has been great. Thank you so much. Dr. Mary Charlton has been our guest. Dr. Charlton is professor of epidemiology at the University of Iowa. She's also the director and principal investigator of the state cancer registry, and she's also the president of the Iowa Cancer Consortium, and an all-around good person. So, and my friend. So thank you so much, Mary, for taking the time. I can only imagine how many requests you have for interviews and for Zoom presentations. And thank you for taking the time to meet with us this evening.
Of course, it's always a pleasure, and love talking with you. You have great questions.
If you are watching us this evening and you know someone that would benefit by watching this program, good news. If they missed it tonight, it's available on demand beginning tomorrow at the Above and Beyond Cancer YouTube channel and also the Mercy Cancer Center website. I hope you'll join us again next week. Thanks, everyone.